Good afternoon, everybody. Welcome to the Australian College of Rural and Remote Medicine webinar. It's all about patient care, incorporating telehealth into general practice. Our presenters today are Dr. Ewen McPhee and Mrs. Wendy McPhee from Emerald Medical Group in Queensland, and Dr. Kearney from the Medical Specialist Services branch in Canberra. My name is Jane Connolly and I will be the moderator for today's webinar. The college hopes you find the webinar informative and enjoyable. A little bit of housekeeping before we start. This is a live broadcast, which means we'll be in the hands of the technology and the infrastructure. That's both yours and ours. Screen refresh and the audio could be affected, and we'll be monitoring this during the presentation to minimise any problems. The webinar is being recorded and will be made available on the college's website. This webinar is full with 100 attendees. We were almost 100% oversubscribed for today. Everybody is muted due to the large audience. However, you can interact by putting questions to the presenters using the GoToWebinar control panel on your right. We would appreciate your feedback following the webinar. A survey will be presented at the end of the event today, and it will also be emailed to you for you to complete later if you prefer. A certificate of attendance will be emailed out to you, and this webinar has been approved for the Australian College of Rural and Remote Medicine's professional development points. I'll now hand over to Dr. Ewen McPhee and Mrs. Wendy McPhee to walk you through their experience of implementing telehealth into their practice.
Okay, thanks very much. I'll see if we can share my screen now. So hopefully it's all going to work. Okay. So just bear with me. This technology won't be a minute. So welcome everybody. I hope that you can hear me. My name's Ewen McPhee. I'm a GP from Emerald. My wife Wendy is the practice manager, and she is hopefully joining on a separate computer because we're having some feedback issues. In the first 30 minutes, what Wendy and I are going to do is talk to you a bit about the why, the how, and the reasons for why we do or why we got into telehealth. And I'm not going to present a lot of facts and figures. I would look forward to any questions that you may have. What our brief is to provide a practical approach to how we've done this, and I guess to also understand a little bit of the business case for why we've been able to make this sustainable. So I'm going to, I guess first of all, just say that we have done a lot of telehealth over the last 18 months, and I think on one day now we do 10 to 15 up to 20 consultations every other day. Not every day of the week, of course, but quite a few. So I'm just going to move forward to the first slide. I guess one of the great issues that came to me in discussing telemedicine and telehealth was the tyranny of distance. And in the early stages of discussions with Medicare locals, with departments around why we should use telehealth, there's a recognition of the fact that safety and travel issues for patients having to travel long distances to see specialists is one of I guess it's the main reason why telemedicine can be such an effective solution, particularly for some but not all health-related problems. We've no doubt, and I'll talk about this a little bit more in a little while, that distance creates barriers to care. and this leads to poorer outcomes and increased costs. And the fact is, a lot of those increased costs with the problems of accessing care for rural people are hidden and they're not measured. And certainly a lot of cost is borne by rural and remote people in accessing care that our city cousins simply don't have to do. I know that there's been a lot of debate and discussion around security issues, the theoretical risks, for example, of Skype. And I always like to think that it only takes one kangaroo through a windscreen to really justify telemedicine. And to be honest, on some of our roads, it's probably more likely to get a kangaroo through your windscreen than having a terrorist from Al-Qaeda listening in on your console about your hemorrhoids. One of the key issues that I've found in why we use telehealth is really about promoting rural health professionals, valuing them for their skills, their knowledge and their experience. My own practice is a teaching practice. We have a number of general practice registrars and medical students attached to the practice, and we actively are engaged in supporting them with doing telemedicine. And there are a number of reasons for that. I guess the key issues are that people don't recognise how important having telemedicine available to rural clinicians can be for them. You can enhance rural retention through being the eyes and the ears and the hands of remote specialists. You can support and enhance clinical skills. And you can be, through beaming in your specialist or other clinician, a source of mentorship, backup and pastoral care for very isolated clinicians. The final thing I've got to say is that it really, for us, has created some really close relationships between specialists and GPs, that we're enhancing the understanding of our specialist clinicians and basically giving them an understanding of the rural and remote context under which we live and work. I'd like to recognise that there's a number of clinical champions that really are promoting the skills, knowledge and experience required in telemedicine and supporting rural clinicians. And certainly in my own area, we've got Sabe Sabasan, who through his work with the Townsville Oncology Unit is delivering to rural and remote people quality cancer care. And we're seeing this, and he does this through working with the local GP and working with the local nursing and allied health professionals. And he tells me that some people he has never seen face to face, just by video conference. The third reason why we're doing this is because we know that the evidence is clearly there that rural people do less well across all health demographics. My Medicare Local has recently done a needs analysis and identified simply those preventative issues such as smoking, alcohol and mental health suffer for lack of access to appropriate support. And as we talk about promoting and expanding telemedicine, we need to think about how we're going to provide support for our allied health professionals, our nurse practitioners, our physician's assistants in delivering on some of these key primary health issues. I've spoken about cancer morbidity, and it's one of the major challenges. And I know through Sabe's work and through the work of Queensland Health that telemedicine is driving effective care in cancer care. And it's an exciting time to be looking at how we can further expand on telemedicine throughout rural and regional communities. I guess the thing to mention is with my talk I'm talking specifically about video conferencing, and I recognise there may well be people in the audience interested in store and forward and other mediums including home care and home monitoring, and I think that this is where we really need to further enhance and explore the possibilities. One thing I wanted to mention around rural health access is the growing body of evidence that delivering emergency support to rural clinicians can improve quality and safety. And what I'm seeing in Queensland is the setup of a unit called the Telemedicine Emergency Support Unit, or TEMSU. And what that seeks to provide is a link between the very isolated clinician, such as a nurse practitioner, and a regional doctor or emergency medicine physician. what we're really seeing in central Queensland and rural Queensland in particular is the ability now for a doctor in a regional centre to talk with a remote nurse or a remote practitioner and manage a problem in a local context in a local facility, and no longer needing to rely on, I guess, emergency medicine physicians in major metropolitan hospitals, but really developing that local context. And I think that's a really exciting aspect of telemedicine, is really not only are we linking remote specialists, but we're also linking clinicians together in the bush. Again, there's some issues around funding for that we need to look at. And certainly Megan will be talking more about the federal aspects of that, and there are some exciting possibilities, certainly in Queensland, around a different approach that Queensland Health is taking towards funding telemedicine, and I'll mention those as well. The final issue about why, it's about bringing care to the community and centering the patient within their medical home. For a long time now, we've seen a lot of people leave their regional centres for care. I know in my own region that over 25 to 30% of people leave the region for medical care. There are obviously many reasons for that, but I think one of the empowering things about telemedicine is the fact that we should be able to turn that expectation that quality care doesn't happen in the bush around on its head, and really start to refocus and recenter our efforts on community practice and centre the patient within their medical home. Medical homes is a concept that refers to putting the patient and their family at the centre of our care. And around that, like an onion, we build in the GP and their practice, local allied health professionals, local nursing, and other care providers. And then we build around that another layer of the onion. We build our local ancillary services and then our hospitals. And then right around the outside of that, obviously our tertiary centres. What telemedicine is allowing us to do, and certainly me, and I've seen it firsthand, is to be able to deliver on specialist quality care in the bush, where I'm the eyes, the hands and the ears of the specialist, and not only that, but also enhancing my learning and the learning of my registrars and my nurse practitioners within my practice. So how do we do it? And I guess I'd like to recognise Dr. Victoria Wade, Clinical Director of the Adelaide Unicare eHealth and Telehealth Unit. I was at a presentation where she spoke about more pilots than Qantas. And there is a sense within various parts of the health community that telemedicine is something new, that it still needs a lot of research, that there's some doubt about its applicability, about its relevance. There is an important aspect of telemedicine that we must still seek to understand its appropriateness. We must seek to understand its cost effectiveness. We must seek to understand the scope of clinical practice and how things are different using telemedicine compared to normal consultations. But the fact is that I've been doing telehealth for probably 10 years, and certainly Queensland Health has been doing it for longer than that. Clinical consultations at a distance is all it is, and for our context it works very well. The evidence, I believe, that telemedicine is a robust medium is in. I've had experience in discussions with people from America, from Alaska and Canada, where they demonstrate very effective models of remote care, including the Alaskan Dental Assistance Model and the Ontario Telehealth Network. So I think that while it's important that we do measure what we do and that we produce evidence to justify the investment and in future telehealth, it's important that we understand that in many ways video conference, face-to-face telemedicine is nothing new. I know in our own experience that we had a very successful trial of psychiatric medicine with consultation of psychiatrists in general practice. Unfortunately, this was discontinued due to the principal leaving, and that's one of the real stumbling blocks, I guess, for telemedicine at the moment. Is it's not quite normalised. We still need our champions to drive telemedicine. What we would like to do is really start to normalise telemedicine and to make it very relevant to day-to-day clinical practice. And we'll talk a little bit more about that. So how do we do it? I'm going to invite Wendy to make some comments soon here about that. But the issue, the points that I have to make is, and with apologies to Forrest Gump, you need to keep it simple. Certainly in Queensland Health there's a lot of very expensive video conferencing suites gathering dust on boardroom walls right across Queensland. What we need to do is deliver simple, effective means of face-to-face consultation. In our practice, we use desktop PCs with over-the-counter cameras. Our internet connection that we use, and surprisingly, we're using 4G wireless, and it is extremely effective. We also have 2 or 3 ADSL connections, and they've grown as our requirements for telemedicine have increased. We haven't got an ISDN connection, we haven't got cable, but certainly we've been able to efficiently deliver 2 or 3 telehealth consultations at one time, plus have our registrars doing some remote supervision and training with their training provider. So it hasn't been a major investment in technology for us to get it up and running. Our equipment is basic desktop computers and laptops. We use Skype and Jabber and a number of other medium, and Skype seems to be very popular amongst our private specialists. Cisco Jabber we use to punch a hole through the firewall of Queensland Health to really liaise and work with our public specialist colleagues. The other issue is finding the right people, and this has been enhanced tremendously by using the ACRM provider database. This current list of specialists with their specialties obviously and their technical requirements allows us access to clinicians for our patients. But the key point is encouraging people to think about telemedicine. What we've done is we've added a little line to every referral that says we are telehealth enabled and we will be very happy to facilitate telehealth consultation. We ask our specialists, would they be able to do a telehealth consultation, particularly in the planning phase when you're thinking about whether a person might need a procedure or whether a person may need further tests, having that telemedicine consultation. There are some other providers, GP2U, Anywhere Healthcare, and they're very effective as well. I might see if I can hand over to Wendy for some practical discussion around how we've set up our system to manage rosters, corralling doctors into one place at the time, and how we work with our specialists, but also the setup. So Wendy, are you online there?
I am.
Yeah.
Basically, we did look at originally putting our telehealth into each doctor's consulting room. We thought that would be convenient. However, what we found was that the doctor wasn't always ready at the time that the specialist and the patient was ready. He might be running behind. So we've actually set up separate rooms that we use for telehealth. These rooms are used for other things as well in between times, but we do have 2 dedicated rooms in the practice that are for telehealth rooms. At the time that the consultation is due to start, one of our nursing staff takes the patient into that room, makes sure that the system is working and that everything's good to go, and then as soon as the specialist is ready, the consultation can start. And the doctor in our practice that's joining the consultation can come in when they're available. Sometimes that happens before the specialist is, but sometimes they come in later on. We've found this works really well because the specialist is able to come on as soon as they're ready, and we don't have that whole problem of everything running late. Most of our nursing staff are quite comfortable with sitting in on telehealth consultations and kicking them off, so that works pretty well. And we do try to book our doctors to sit in on the consultation if possible for part of it or all of it as a learning experience for them and to help the patient with that interpretation of what the specialist is saying and follow up that's needed. As far as connecting goes, Queensland Health has got a test link site that you can connect to check that everything is working, which we tend to do before any Jabber consultations, just to make sure you can see the traffic on Bowen Bridge Road, and then you know it's all good to go. We have found that a bit of nagging has been necessary to get the telehealth happening at times, particularly into the Queensland Health network. We had one patient who was being asked to drive from Emerald to Rockhampton so that they could sit in on a telehealth with a doctor who was in Brisbane, and we thought that was silly. That's a 6-hour round trip to sit in on a conference by telehealth. So with a bit of persistent nagging, Queensland Health came on board, and we ended up doing a 3-way telehealth with the nurse in the clinic in Rockhampton, the specialist in Brisbane, and the patient in Emerald. And that worked really well, and now that they've seen we can do it, it's happening more and more, so that's a bit of a win. We have found with the specialists that if you ask, they will often come on board. So we've got a lot of relationships with specialists that we would have referred to anyway, that we've said to them, hey, how about setting yourself up for telehealth? And they've done so, and they're becoming converts, so that's great. I'll hand back to Ewen now to go on with the next slide.
Thanks very much, Wendy. So what we wanted to cover with this was just the fact that we're not using any high-powered equipment. We haven't spent a lot of money online with high-tech cameras and things like that. I guess the future is still, we need to consider things like home observation, home monitoring. We use store and forward as well, particularly for Telederm, which is an Acrim dermatology service. What Wendy has probably very modestly talked about is really running that back room. As you probably all know, trying to get doctors to do something is like herding cats, and having a very robust mechanism for doing a pre-test before you start the telehealth clinic, making sure that people have all the clinical information that's available, so specialist letters are delivered to the specialist, any other clinical information is required, making sure that it's working well. If the doctor's not available, having trained staff that are able to take notes, and obviously, and I'm going to jump to the next slide here, thinking about the issues of quality and safety and sustainability. Basically, from a medico-legal perspective, I think of a telemedicine consultation as no different from a face-to-face consultation with respect to how you conduct yourself in a professional manner. The issues that I believe are really important, though, are adequate consent, good records to make sure everybody's well informed. When you're online, you must indicate who's in the room and guarantee privacy. It's important, and as Wendy has said, we've got our dedicated rooms that we use where we are relatively soundproofed and private. And that it's really important that we make sure that when we're talking about a consultation with a patient, that the specialist is aware of who's in the room. I had a consultation the other day where so I'm just looking at a question. I can't actually see the question box very well so to answer them, so I might get you to talk to that in a moment. So, all right, just a couple of comments then, and I might ask Jane or somebody to just ask that question in a moment. I just wanted to highlight a couple of things. If we could make reference to the ACRM Telehealth Advisory Committee Standards Framework and make reference to the medico-legal aspects of telemedicine. And I'd like you to direct you to the MDA National website where they have a telemedicine provider's information handbook. And I think that's a very detailed account of what you need to know to deliver on safety and quality and make sure you're protected medico-legally. So could I ask somebody just if they can to read that question, because I'm not seeing that panel very well.
Hi Ewan, there's a couple of questions that are probably related that you could respond to together. The first one is, do you use this as a teaching experience for your registrars in the practice? And also, have you any experience with teleophthalmology that you can share?
Okay, thank you. The answer to the first question is yes, we do. What we've done is, and particularly with the incentives, we made sure that all of our registrars had an opportunity to first of all sit in with telemedicine consultations and learn how it looks and feels, because I think exposing to people is critical if you want to make these new interventions successful. So I think that yes, it is important, and then encouraging the registrars to think about their referrals, saying, look, do you really need this person to drive essentially 700 kilometres to see the specialist, or can you involve the specialist via telemedicine first before sending that person away? And certainly, first of all, giving them experience and then demonstrating it is really effective. The other aspect of that comment is that the training providers are really starting to embrace video conferencing to deliver remote training, and certainly the training providers I'm used to are really embracing that, and also using our video conferencing facilities for external clinical teaching visits. So what we're doing now, which I think is a little bit innovative, is having our video conferencing suite available and in the room with a GP registrar who's doing their consultations, and having a remote GP, a remote clinical or medical educator in there with them, sort of like a fly on the wall, where both patient and doctor can see that person, and it seems to be really well received by patients and very well received by GP registrars. As far as teleophthalmology, to be honest, no, I haven't. We're very lucky, I guess, in Emerald that we have a visiting ophthalmologist, so we haven't had a great demand, but I certainly recognise the work that's been done in Western Australia through Andrew up in the north there using iPhones. I think that there's certainly a tremendous scope for innovation in these areas. Was there anything else?
Yes, there's a couple of more questions coming through. How is trust important when providing telemedicine? Does trust form differently with patients virtually rather than face-to-face?
That's a very good question. My impression and my experience is that once you actually put the patient in with the clinician, it's almost like there's this magical, the technology just disappears. And I know that sounds a bit whimsical, but the fact is I've seen it happen, that once you actually, and this is a real difference between a phone consultation, I think, and a video consultation, that the body language, the face-to-face, seeing a person, being able to talk to them, the technology becomes secondary once that relationship is established. I think that there's a lot of work to be done, though, in first of all briefing patients about what they should expect and checking back with the patient to make sure that they understand what's being told. The third aspect of that is having a trusted person in the room with the patient. Now, that in my case either be a family member, or it'll certainly have one of my practice nurses or myself or one of my registrars in there with them. But really it's almost magical that how the technology takes a back step once the people are engaging with each other. So I hope that answers the question.
Time for one more, Ewen.
Yep.
From the specialist viewpoint, how do you overcome the disadvantages of practice software and provide a comprehensive referral letter?
Again, I think that it really need to communicate well between GP and specialist. If the information is not adequate, it needs to be made so. And what we've done is we've oftentimes used specialists who are very comfortable with us as GPs, and we've developed a good working relationship. And it's really just about enhancing that relationship with our trusted specialists through the use of telemedicine. There's a couple of aspects. Obviously, the personally controlled e-health record is a health summary at the moment, but we really need to explore how we can create a value-added information portal. So for telemedicine particularly, all clinicians have access to the same information. There's obviously various other technical medical record systems across Australia that already do that, but we need something that can cover public, private, divides, interstate and everything, and I think the PCHR will be an interesting thing to explore. So what I might do is I've only got 5 minutes more, and I would like Megan to chat. Just going to move to the next slide. We're going to talk briefly about the business case, and I'm going to ask Wendy to spend a bit of time chatting about that. But first of all, just to show us a little bit of data from my own calculations. The first is that with Queensland Health is rapidly increasing the numbers of telemedicine cases it's doing, and to mention that from a business case point of view for the public hospitals, Queensland has taken the interesting position of uncapping telehealth funding. So you can essentially, as a rural hospital, do as much telehealth as you like and you'll be funded for it. The second issue is funding of both ends. The current federal government funding for public hospital telehealth only funds the specialist end. What Queensland has done is said, no, we're going to do both ends and we're going to uncap it to really promote that as a new way of doing things. Queensland Health is also looking at both outpatient and inpatient facilities. The second issue that we needed to look at, and Megan will chat about this more, is really the aspect of the telemedicine incentives. And in my own area, we had a rapid uptake or number of practitioners, but this wasn't really reflected with an exponential growth in the number of consultations that were happening. Certainly, in my own calculations, my practice had probably done about 1/3 of all consultations in the whole region, when there should have been 38 practices registered. So we need to really go to the next level with this. The final slide I wanted to just show you is that with the growth in item numbers, what we're really using mostly is our nurse practitioners in doing nurse-led and nurse-supported video consultations, particularly with our specialist colleagues. We have a visiting plastic surgeon who does most of his follow-up using our nurse practitioners and nurses in our practice. We've had a fairly flat number of GP consultations, but it's really our nurse-led and our other practitioner-led consultations which are really taking off. So what I'm going to do is just jump back and ask Wendy in the last few minutes just to perhaps just make a bit of a comment about the issues of billing. What do you think are the important issues in making the business case?
Yeah, thanks. Basically, we did it for the patients. So the business case wasn't our primary reason for doing it, and we would keep doing it for the patients to get them the best care that we can in this area. Having said that, the incentives certainly did make it financially rewarding to get on board with telehealth, and the fact that there is funding, like there are Medicare item numbers there to bill for both the nurse time or the doctor's time, whichever is relevant, do make it easier to convince busy doctors to take time out of their normal consultations, consulting, and do telehealth because they do get paid for it. I think once they've done one or two, they can see the advantages of it, and they're actually going looking for things that they can do by telehealth because they just get such excellent feedback from the specialists and feel much more part of the whole patient care than they do when the specialist, when the patient has to go away to see the specialist. Just one other thing that I would mention that has been a major advantage for our practice is the fact that if we do telehealth, there's people able to participate in the consultations that wouldn't normally be able to do that for patients from a rural area. So there's we're able to have like school teachers come in and take part in the telehealth consultation with the paediatrician. We can have extended family members are able to come in, and the savings in travel and time away from work just all make sense. So we're very happy to keep doing telehealth. Works really well in our practice.
Thanks very much, Wendy. So what I'm going to do is I'm just going to jump down to our Nike ad, and to be honest, it's just about doing it. We're nothing special. We're no experts in IT or anything, though I'm sure my son, who's an IT expert, probably rused the day his parents bought a computer. But anyway, so look, it's really a matter of just doing it. Certainly for your basic face-to-face video consultations, it really works well. The future I'm really enthusiastic about. Certainly Queensland is working on a comprehensive process of joining public and private providers, starting to think about how we can facilitate and support our allied health and our nursing professionals in the most rural and remote locations. So I think it's a real watch this space. But I'll hand over to the organisers and Megan, and thanks very much for your time.
Jane, should I start?
Yep.
Oh, thanks. Look, thanks, Ewen. I'm just going to have to fiddle with a bit of technology myself, I think, here. So, hi everyone. I'm Megan Kearney. I'm the Assistant Secretary in the Medical Specialist Services branch of the Department of Health here in Canberra. And I don't know if anyone else is looking out over snow today, but I am. It's a beautiful day if you're a skier in Canberra. Jane, I now can't see my own screen. So does that mean that other people can see my screen or not?
Wendy, we can see the presentation, yes. So we're on the beginning of the presentation.
Right. So if I scroll through to mine, or
yes,
is what I'm doing, is that all right? And you can tell me if, perhaps you can tell me if things don't work from your end, and we'll see how we go. So good afternoon, everyone. So what I'm going to talk to you about today is some of the policy underpinnings of the telehealth program, and then give you a bit of information about the current arrangements and how they've changed over time, and the rationale for that. I won't spend much time describing the current arrangements because I imagine that this audience is probably familiar with it, but I thought there might be some people who haven't dipped their toe into the water of telehealth yet, so it was worth including them in the presentation. And then I was just going to finish off by talking a bit about how the arrangements are going to change as of the 30th of June. So look, the first thing to talk about is this initiative and how it came about. So those of you who were around at that time would recognise it was an initiative of the previous government, and from the 1st of July 2011 these items were introduced into the MBS. Prior to that there were some telehealth items available for psychiatry, but and they'd been on the schedule for some time, but the access, the use of those items had not been very high. And I suppose in terms of the policy design in putting these new items into place in the MBS, there was some thought given about how we could encourage practitioners to take up the items and enable these services to be rolled out to patients. So the first thing to recognise, of course, is that the aim of the program was to enable patients who live in rural and regional Australia to better access specialist services. So it was addressing a gap around service provision, and we all recognise, as Ewen has talked about, the barriers to patients accessing those necessary services, and they go to not just geography but the financial aspects of actually having to travel into major urban centres to see specialists, and also you know, despite the efforts in getting specialists to get out there into rural Australia, that hasn't produced everything that we might desire in that space. So it had a specific focus, which was around better access to specialist services, you know, as opposed to other services which are funded through the MBS. From the 1st of July 2011, there are a number of items introduced which were for services provided by specialists, and they included the whole gamut of specialist consultations, and so not just consultant physicians but psychiatrists and any other medical specialist. And those items were, the way they're set up is that the specialist would bill, you know, the usual item that is associated with a specialist attendance, and these items provide for fees that are 50% or rebates that are 50% more than the comparable face-to-face consultation. Now, it's important to recognise that in relation to the fees that are applicable to telehealth items, whether they be specialist end items or patient end support items, that those fees, being the with the increased with the 50% increase for specialists and 35% or so increase for GPs, those fees continue after 30 June this year. In relation to the patient end, of course, there were, and this was the kind of novel aspect in a way of the program, was that unlike in the previous program of telehealth-enabled psychiatry services, the new services that came into line or came into play from the 1st of July 2011 provided for patient end support services where there was a clinical need for a GP, nurse practitioner, midwife or practice nurse or Aboriginal health worker to provide assistance to patients for them to access the specialist services. And those services follow the normal time-tiered structure of primary care type services, but with fees that are approximately 35% higher than the face-to-face consultations. And importantly, as I just said, that fee structure continues after 30 June this year. As you'd be aware, a range of financial incentives were put into place in July 2011, and they were really to incentivise both general practitioners and specialists to try out telehealth. So they've been largely successful, and a lot of people have tried out telehealth, and I'll give you some facts and figures at the moment. But they were always designed to be a time-limited incentive program. And you know, to encourage people to, you know, change practice in a way which would see these services supported into the future. But nevertheless, they were generous incentives, and there's maybe some criticism of how they were rolled out initially, and that certainly led to some refinement of the program as we went along. You know, in looking at the policy design originally, and then of course in my branch, we tracked the implementation of the program and how it was being rolled out, and that led to some changes that were instituted in November 2012 to ensure that the funding was better targeted to patients who are benefiting from the services. The principal changes were in relation to geographical eligibility for patients, so it was so services were better targeted to people in urban and regional Australia as opposed to people who lived in the urban fringe. And also there was a requirement put into place that the patient and the doctor had to be located at least 15 kilometres apart, because it really wasn't to enable access of patients to specialist services when those services were locally available in rural Australia, but where they were meant to address problems where geography served as a barrier to care. So for instance, a patient who lives in say Orange in New South Wales, if that patient is seeing a local specialist, then telehealth rebates are not available, but if the patient who lives in Orange is accessing service from a specialist who lives in Sydney, then the Medicare, then the MBS items are available. And what we've seen is that in some instances where you have visiting specialists, they may see a patient, you know, face to face when they visit Orange or the regional community where they provide services, but then for the follow-up attendances, the patient may link in through an MBS-funded telehealth service to that specialist rooms in the major urban centre. I suppose one of the things that needed to be addressed was that some of you may be surprised to know that with the original boundaries of the telehealth program, quite large centres in Australia were actually telehealth eligible, and a good example was large parts of Canberra, in fact, were telehealth eligible. And with the changes in November, from 1 January 2013, that geographic boundaries and the amendments, as I said, meant that patients who live in major cities, where we're talking about quite good service provision, would no longer be eligible, and as I said, services better focused on people in truly regional and rural Australia. So, they're the changes that were made 12 months or more, or a couple of years ago now, coming up to a couple of years. I just wanted to touch on, because I know a lot of people have some concerns about what's happening on the 30th of June this year. So, as always has been the plan, the financial incentives will cease, and they're ceasing from the 30th of June this year. And so those incentives that will no longer be available are the onboard incentives, so the upfront lump sum payments that were made to providers to try out telehealth. And also there were some per service incentive payments which were provided to both GPs and specialists, which will no longer be available. But as I've said, the fee loadings that were part of the policy design and implemented from the initial date continue. As I said, it's always been intended that those incentives would be time limited, and they're really an effort to try to get providers to try out these services, but recognising that in the medium to longer term that these services should be mainstreamed into practice. I just wanted to let you know a little bit about what activity we've had to date. So by March this year, there's been about 170,000 MBS-funded telehealth services provided to about 62,000 patients and by close to 10,000 practitioners. Quite a large percentage, I can't recall the numbers now, but I think it's about 10% of specialists, might even be more, have actually tried telehealth. There's actually a concentration of services in psychiatry, which is understandable given the consultative nature of that discipline. And there's also been quite good access or quite good uptake in aged care facilities. So 221 aged care facilities have provided telehealth services. In relation to GP services, 6,390 GPs have provided close to 60,000 telehealth services as of the 31st of March this year. Finally, I just wanted to provide you a bit of information. ACRM has helped here too in giving you a few links to more information that you can find about MBS funded services. MBS Online is a good resource for telling you all about the program rules and providing some update in terms of the rollout of the program and that kind of information. So I'd recommend people look at that if they like. And I haven't looked at the question, but I'm going to anticipate one question in relation to telehealth and co-payments. So telehealth, the co-payments measure, the budget measure, which is to be rolled out from the 1st of July 2015, the GP telehealth items are not subject to the co-payment arrangements. So those items continue to be provided in the way that they're provided now, similar to a lot of the care planning items and the like, which similarly are not affected by the co-payment arrangement. So I might leave it there and hand back to Jane, unless Jane wants to tell me of any questions, which I'll try and answer if I can.
Thanks, Megan. There are actually two questions. The first question is in 3 parts. The first one is it likely you'll open telehealth to everyone regardless of location? And the second part is open telehealth to all providers, so the same part of that question. And
Yep.
part 3, enable telehealth for all item numbers, all with or without the added 50%.
Yeah, look, good questions. Those are decisions for government, obviously. So, you know, we as a department provide, you know, advice to government and, you know, at the request of government. So if government was to come to us saying, well, look, we're thinking of exploring this issue, you know, of expanding telehealth arrangements, can you give us advice about what that would mean in terms of the implementation of that and the impacts upon budget? You know, we would do that work if we were asked to, but to date, you know, we haven't been asked to, so really I suppose it's up to professional organisations, AMA, craft groups and the like, if they think that there's a need for these services to be expanded in terms of the range of services, the range of providers and the like, then you know, please make your submissions to government and see how you go. But as I said, those are fundamentally decisions for government about how a program may be expanded or not.
Okay. Next question is, what about? Sorry.
Sorry, it's Ewen here. I just wanted to flag that that's really critical, that where we want to progress these discussions around enhancing telehealth to access nurse practitioners, allied health professionals and also GP to patient consultations, we need to make the business case, we need to make the case to government, and I'd encourage all the listeners to certainly put their minds to how they might do that.
Yeah. I mean, I think, it's Megan here again, I think if there was a case to be made, you know, there's, you know, governments would look to, you know, organisations like ACRM for advice and the like, but also around where the next phase might be. So, you know, obviously the context for this is around, you know, the big driver for it is around service provision to rural and regional patients, and you know, so you know, there might, you know, you might look at, you know, service needs around allied health provision or GP service provision. So GPs themselves who are in rural and regional Australia who have patients who find it difficult to access their services because they live 100 kilometres out of town, whatever it might be. You know, so I think you know, that's the kind of place that people might want to look to go. I think it's a long look. I really can't. I don't know the views of this particular minister. There hasn't been any discussion about changing telehealth arrangements, but I suppose, you know, from our perspective, that they're the kinds of queries that we get from the moment, and they seem to have some good clinical sense around those kinds of services which lend themselves to telehealth service provision. You know, psychology and speech therapy, optometry and the like, you know, where they're, you know, people might want to think about trying to make a case.
Megan, the next question was, what about the bulk billing incentive for GPs?
That's, I think, yeah, no, look, I hope I'm not going to make a mistake on this, sorry about this, but as I understand it, that's an incentive payment that's linked to telehealth, so that will be no longer available as well. If I'm wrong about that, I will let you know, but my understanding is the bulk billing incentive is one of the incentive payments that will cease as of the 30th of June.
Okay. And there was a question about the numbers for aged care, asking whether you have the number of consultations done in an aged care facility.
I don't have it in front of me, no, sorry.
Okay, so we might be able to provide that later.
Yep, if you like, yep.
And the final question, just before we finish for today, is are there any GPs out there that are giving a GP consult to remote patients with a nursing outpost to facilitate? Are you therefore going outside Medicare and charging entirely private?
Well, that would be not provided for in an MBS arrangement, but there may well be people who are providing these services privately. Or through other funding arrangements. So, you know, if I'm thinking about remote health in the Northern Territory, you know, I'm not sure what they're doing in that space in terms of nurse-led clinics in remote Northern Territory and their links into district health officers and the like through Northern Territory Health. But yeah, I mean, I know that they've had long-standing telephone-based clinics, but whether they've moved to video conferencing, I don't know.
Okay, thank you.
It's Ewen here. I certainly know that the RFDS is interested.
Yeah, yeah.
Sorry,
so,
I know the RFDS is certainly.
Yeah. So they would be outside MBS funded arrangements at the moment.
Okay, thank you, Megan. There were a number of other questions for Ewen, and there's some questions that are coming in now. What we'll do with those questions is we'll put them on our discussion forum on the ACRM eHealth website, and you'll be able to see the answers to those and also post any new questions that come to mind since the webinar today. So I'd like to thank you for your time in attending the college's webinar. If you have any further questions, as I'd said, you can put those on our discussion forum and I'll send you some details about that. Stay on the line and complete the feedback survey now if you have time, or look out for the email that will come in the next day for you to provide that feedback. So thank you everybody, and hope you have a nice day.
Thanks, Jen. Thank you.